Hello everyone. Today I'm going to talk about exercise prescription after an individual has received a cardiac transplant. A cardiac transplant is a patient whose heart will no longer be able to sustain life within a short period of time. The solution to this problem is receiving a new heart. In order to receive a new heart, patients must endure a screening process that determines how mentally and physically equipped they are to receive the new heart. Some of these criteria are based on whether the organs are functional, if the individual is a smoker or has been consuming alcohol, inherited risk factors, and their willingness to take care of their new heart by taking their medications. After the screening process, it is determined whether or not the individual is fit to receive a new heart. If they are, then they are placed on the list where they will wait for a match. This could take an extended period of time. When the surgeons find a match, the procedure could take anywhere from 4 to 8 hours. Here is a video showing the process in a little more detail. According to the United Network for Organ Sharing, UNOS, there were 3,408 heart transplants and 32 heart-lung transplants in 2018. In the current count for 2019, 2,705 heart transplants have been performed and 32 heart-lung transplants. There are many challenges that can be faced during the process, including a limited donor supply. Ultimately, the person donating has to reach complete organ death. Another barrier can be the location of the organ when the person reaches organ death. The organ cannot travel too far away, or it might not be an effective transplant. Heart transplants are generally needed by people with congenital heart diseases. There are 18 known diseases, including aortic valve stenosis, which is narrowing of the aortic valve, where the blood is pumped from the heart to the rest of the body. Another defect could be the tetralogy of Fallot, which is shown in the diagram on the right. This is where a narrowing of the right ventricular outflow to the lungs via the pulmonary valve causes a septal defect between the ventricles. This also causes the walls of the right ventricle to become thicker, otherwise known as hypertrophy. End-stage heart failure is also an indication of the need of a heart transplant. This is when the heart cannot pump like it is supposed to due to coronary heart disease, high blood pressure, cardiomyopathy, the after effects of a heart attack, viral heart infections, inherited forms of heart disease, or a leaking or blocked heart valve. Overall, there are many pathologies that could cause someone to need a heart transplant. There are two different types of heart transplants, orthopedic and heterotopic. The more traditional heart transplant is the orthopedic transplant. This is when the diseased heart is removed from the chest cavity. The donor heart that the recipient waited for is now going to be placed in the chest cavity and replace the donor heart. replace the original heart. The heterotopic heart transplant is where the existing heart stays in the chest cavity and the donor heart is implanted along with the original heart in order to assist the original heart with pumping blood around the body. After a heart transplant, you might guess that there can be many different complications. The complication with the highest percent of incidence is infection, which is the most prevalent within 20 years of surgery at almost 95% incidence. Rejection is prevalent within 5 years of surgery, reaching about 45% rate of incidence. Cardiac allograft vasculopathy, CAV, is prevalent up to about 9 years following surgery, occurring at about 45% incidence. Malignancy could occur up to about 15 years after the surgery with about a 45% rate of incidence. Finally, chronic kidney disease could occur up to 9 years post-surgery. This occurs at about 25% incidence. Regardless of the complications, each continues to increase in incidence as the patient moves further away from their initial procedure. Other complications can include graft failure, hyperlipidemia, hypertension, and diabetes mellitus. Immunosuppressive medications are typically used to treat heart transplant patients. These are used because when the body has a foreign object in it, it tends to attack itself. As a result, patients take immunosuppressives in order to make the immune system less prevalent, allowing for the heart to work the way it should without interruption. Unfortunately, as with many drug therapies, there are side effects. Luckily, exercise is able to cure many of these side effects, including osteoporosis. Resistance training can help treat the condition by increasing bone density. We want to make sure that the patient is performing a lot of weight-bearing exercises and adding weight as well to help their bones. It can cause a decrease in muscle function, resulting in delays, decreased coordination, and decreased adaptability. Exercise can help train the muscles to work better together, which would help with these side effects of the medication. Hyperglycemia can be a side effect as well. If this is the case, then blood glucose levels should be monitored before, during, and after exercise. Exercise is also a useful way to lower blood sugar. After an individual is recovered from a heart transplant surgery, they should begin exercising because it can be extremely beneficial to the full recovery of the procedure. It can help improve exercise capacity, the overall quality of someone's life, bone mineral density, and sarcopenia. Many patients who have undergone a surgery of this magnitude also had cardiovascular risk factors prior to surgery. Exercise, of course, has helped to reduce these risk factors such as obesity, hypertension, and glucose intolerance. Now we will move on to evaluating the case study involving Mr. M. Mr. M is an 80-year-old male who stands 178 centimeters tall and weighs 97.5 kilograms. His BMI is 30.8 kilograms per meter squared. He has a blood pressure of 134/86 millimeters of mercury, making him hypertensive with an elevated blood pressure post-cardiac transplant. He has an HDL of 48 milligrams per deciliter, an LDL of 82 milligrams per deciliter, and a triglyceride level of 154 milligrams per deciliter. He used to smoke, however, he quit 30 years prior. There was no family history of CVD, however, he possesses risk factors. Due to his lack of exercise capacity and 3 knee surgeries, Mr. M has been sedentary for 5 years now. He would like to get back into attending the gym with his wife and walking around the indoor track there. He also enjoys getting into the pool and using the buoyant water weights because the water is therapeutic to his knees. The goal of his exercise program is to lose a little weight in order to become more mobile and to ensure that he can keep up with his new heart. After any heart transplant, the heart becomes denervated. Any previous peripheral abnormalities are not cured, and this causes a reduced exercise capacity. In order to test Mr. M, we should use more gradual testing protocols because the heart rate response could be attenuated. For his aerobic fitness testing, we could test either using the treadmill or the cycle ergometer. For treadmill testing, a ramp protocol could be used to increasing the METs by one or one or less per 30 seconds to a minute. The incremental protocol is also a good test for Mr. M. This is increasing the intensity 1 to 2 METs every 2 to 3 minutes. The Naughton's protocol is also prevalent in that each step is in 2-minute increments with increases in speed and gradient after the third step. For the cycle ergometer protocol, the subject should be tested using a ramp protocol where intensity is increased by 10 to 15 watts per minute or 25 to 30 watts every 2 to 3 minutes. For resistance testing, a 10 repetition max test should be used because there should not be too much stress put on the heart from maximal exertion. For flexibility testing, a modified sit and reach would be sufficient. Mr. M should use the following exercise prescription once he is cleared for exercise and tested. For aerobic training, he should perform it 3 to 5 days a week at an RPE of 11 to 14 on the scale of 6 to 20. He should start at about 20 minutes a day and work up to 60 minutes per day as he becomes more tolerant to exercise. Aerobic exercises should include walking around the indoor track at his gym, walking laps in the pool, and light cycling. For resistance training, he should be performing this 1 to 2 days a week non-consecutively. Lower body training should be about 50% of the patient's 1 rep max and progress as strength increases. Upper body training should begin at 40% of the 1 rep max and should gradually increase to 70%. Upper body activity should be limited for up to 12 weeks post-surgery due to the medial sternotomy that could be compromised if not eased into exercise. Each exercise should be performed 1 to 2 sets of 10 to 15 repetitions. Exercises can include band and body weight work until the client is comfortable and cleared to add weight. There should be a lot of weight-bearing exercises to compensate for the bone loss from the immunosuppressive medications. Flexibility should be performed 2 to 3 days a week, stretching to slight discomfort. They should be held for 30 seconds each, 2 to 4 times per exercise. Dynamic stretching should take place before exercise and static post-exercise. There are, of course, a few considerations that need to be taken into account before someone can exercise while recovering from a heart transplant. An elevated heart rate will be prevalent because of the absence of the parasympathetic innervation. The response to exercise will not be dramatic and will take longer to recover. This could be seen up to about 2 minutes post-exercise when the heart rate could be the same as the exercising heart rate. The intensity of exercise should not be based off of the heart rate. Heart transplant patients will have an elevated resting blood pressure. The bone density of patients could be low because of the immunosuppressants. Other comorbidities should be monitored for diabetes, such as diabetes and hypertension. Finally, upper extremity range of motion should be limited for the first 12 weeks post-surgery. Often many patients will begin their cardiac rehabilitation program 4 weeks post-surgery. Overall, common misconceptions have led people to think that exercise should not be performed by someone who had a heart transplant. This is not the case, and in fact, exercise is encouraged in order to improve their overall quality of life. In order to perform exercise, we need to make sure that all risk factors are taken into account to reduce the risk of further cardiac injury.